Recording's in progress. Okay. Good morning. We are so excited for our speaker today. This is the Office of Faculty Development sponsored Grand Rounds. So huge thanks to Dr. Sylvia Choi and Dr. Noelle Spears for giving us time in this forum to bring nationally renowned speakers in the area of faculty and professional development. So today we have Dr. Eva Aagaard. She's the Carol B. and Jerome T. Loeb Professor of Medical Education, the Vice Chancellor for Medical Education, and Senior Associate Dean for Education at Washington University School of Medicine. As a practicing general internist in her current leadership role, she also oversees medical education across the continuum. So that includes UME, GME, and continuing medical education. This includes spearheading a large-scale curriculum reform effort in the medical school program, promoting the development of multiple initiatives to promote the career development and success of educators on campus. Nationally, she has had amazing impact. She led the development of the Society of General Internal Medicine TEACH program and partnered to develop the MedEd Scholarship Faculty Development Program. Dr. Aagaard is a former member of the American Board of Internal Medicine Subspecialties, a former council member of the Society of General Internal Medicine, and she continues to participate actively in the National Board of Medical Examiners as a reviewer for licensing exam content. She served as a core member of the Milestones in Internal Medicine Writing Committee, leading the next accreditation system at the ACGME. Her areas of interest, as you can tell, include curriculum reform, competency-based education, and assessment. She's passionate about mentoring, coaching, and sponsorship and speaks widely on these topics. She's won more than 16 awards for clinical excellence, teaching, and humanism in medicine, including the University of Colorado's President's Teaching Award, the Society of General Internal Medicine Mid-Career Mentoring Award, the Elizabeth Gee Award for the Advancement of Women, and the Washington University Distinguished Faculty Award. In her session today, she will describe the literature and evidence regarding unprofessional and challenging behavior in medical learners and faculty, as well as the evidence regarding how to support and change these challenging behaviors. We are so excited. Please join me in welcoming Dr. Eva Aagaard.
Thank you. Can everybody hear me okay? Okay, wonderful. I'm really looking forward to this talk today because every time I talk about this subject, I learn something from the people who I talk to about it. And it's something that in my mind, I've been evolving my thoughts about for now over 20 years, specifically in this domain. And I think throughout today, this morning, we're going to talk specifically about professionalism and remediation of communicative and professional behaviors. But throughout the day today, we'll have some other meetings where we'll get to talk about remediation more broadly. If I can make this thing work, let me see. Maybe I need to turn it back on again. Okay, we'll go. All right. So these are the core objectives I have for today. We're going to begin by talking about the evidence regarding reporting, mitigation, and intervention for challenging trainee and physician behaviors. We'll talk about some specific remediation strategies that have evidence to suggest they may be effective. And then I'll spend a little bit of time talking about and thinking about lessons learned from developing remediation programs. There are two published programs, one of which we developed at University of Colorado when I was there, one from Penn that we'll talk a little bit about. And then I'll talk about how that's informed my decision-making for what we're building at WashU. Before we begin, I think it's really important for us to ground ourselves in a common challenge, which is that we actually do not have a shared definition of professionalism. And so I'm going to share a couple of them. And the first one, and the one I really like maybe the most, and I think it's particularly valuable right now as we think about what's happening in the world, is this one. And it comes from the Royal College of Physicians in London. So a set of values, behaviors, and relationships that underpins, and I think this is really the key, underpins the trust the public has in doctors. So it gets at the why. Why does professionalism matter? It matters because of the trust and the relationship we have with society, okay? And in fact, society is what grants us our privilege of being self-governing. So in case we're not all like fully aware of this fundamental situation, which is that we as a profession are one of the few self-governed professions in the world, and we are self-governed because the public grants us that privilege. The second definition comes out of CanMeds, which is sort of the Canadian version of the competency movement, one I like very much. And they talk mostly about values, virtues, and some behaviors. And you'll see as we talk about professionalism that we often intermingle the concepts of the values and virtues that we expect of people and the behaviors we expect of people. And this can frequently come into conflict. And so you'll see again in CanMeds, patient comes at the center, followed by compassion and honesty, but also core elements of maintaining being up to date in your specialty, being respectful, and being compassionate. And these things these values and virtues flow through almost all definitions of professionalism. And then lastly, we have the ACGME competencies. So ACGME, when it moved to the Milestones Project and competency-based education, moved to the concept that it needed to define behaviors that were expected of a professional that were both observable and evaluable. So that's why you see a movement away from values and virtues and more towards this, which is a behavioral framework, because these were things that they thought that we all thought could be observed and may be valued. So compassion, integrity, and respect, responsiveness to patient needs that supersedes self-interest. Interesting concept that is coming under fire at the moment. Respect for patient privacy and autonomy, accountability to patients, society, and the profession, and sensitivity and responsiveness to a diverse patient population. And this definition has been in place since about 2014 or so at the ACGME. So now what do we know about struggling learners? Okay, and this is pretty interesting. So 10 to 20% of people in any given cohort will struggle at some point in their training. That 10 to 20% is true across medical school, residency, fellowship, and faculty. Okay, so this is not a problem that is only in training and then never, and those people are not the same people. So in other words, some people will continue to struggle over time, but the majority of people actually have moments in time when they struggle, okay? And so that's an important concept that we'll come back to. The second is that we know that unprofessional behavior occurs in up to 20% of medical students, and you would expect unprofessional behavior, if you believe in a developmental framework, to be more common in more junior learners and then to develop as it goes up. So 20% of students have unprofessional behavior, but it's only reported about 3 to 5% of the time, and probably less than that in the medical student performance evaluation, also known as the Dean's Letter, for those of us who are a little older. And then 5% of teaching evaluations show professionalism lapses. And that means significant professionalism lapses. And this is finally the really important point I want to make, which is only less than 2%. We often think of professionalism lapses as being a horrible thing, but in fact, they are relatively common, and less than 2% of the people who manifest them are actually not responsive to reflection and improvement. So it is a very small percentage of the people who are truly bad actors, but we frequently make plans and processes around that very small percent. I really like this framework for thinking about unprofessional behavior. It clusters things into 4 big categories. The first being involvement, something we see a lot, right? People showing up late or not showing up at all or not meeting deadlines, right? This is one domain, and we're going to talk about why this domain, which many people think of as being not important, is actually incredibly important, especially early in training. The second is integrity, things like cheating, lying, plagiarism, not following policies and processes. And then the one that I see a lot has to do with interaction. This is the one that shows up most commonly. These are things like poor, inappropriate communication skills, bullying, and abusive conduct. And then the last one, that one that is much less common, but takes a huge amount of time is the lack of introspection. So lack of insight or perspective taking, not understanding the other person who's across the room from them, who they're talking to, or a failure to take and respond to feedback. So why does this matter? And this goes back to what I was saying before. So there has been a strong correlation shown between unprofessional behavior in medical school and residency and disciplinary review during residency. It's 5 times more likely. The need for remediation or counseling, obviously. And then this is the important one, subsequent disciplinary action by a state medical board. In fact, there are 2 primary predictors of disciplinary action by a state medical licensing board. One of them is this. The other one used to be Step 2 CS, which was why the licensing boards fought for that test so hard. Okay. Failure of that test was highly predictive of later sanctions. The second thing is that among residents and faculty, it's associated with poor adherence to practice guidelines, which impacts patients, loss of patients, loss of staff morale or low staff morale, and turnover, which causes the system significant money, medical errors and adverse outcomes, and malpractice costs. It also has some significant impacts more broadly on the environment in which we work. So when there is a person who has significant professional behavior concerns within an environment, it results in anger and resentment when people feel like nothing has been done about that problem. It also can result in anger and resentment from the person who is accused of the behavior. Frequently, they feel like they're being targeted or like that the situation is unfair, and we'll talk about why that might be. It causes overwork, exhaustion, and fear of retaliation from people who are in the environment, who frequently have to cover for individuals when they get pulled out of routine rotations. And this subsequently impacts the climate and culture of the entire environment. So now we've talked a little bit about the background around professionalism and about remediation in struggling learners. Now we're going to talk a little bit about how we become professionals. So the literature on professional identity formation. So we're all sort of thinking about it in the same theoretical framework. So you guys are mostly pediatricians, so this will make so much sense to you, whereas for other people, I think it is frequently challenging. So the concept of professional identity formation largely was formed by a couple, Cruis and Cruis, who actually have won multiple national awards for their work in this space. And essentially what they describe is that all of us come into professional training with our own identities, those that we developed from birth, and that were given to us through our multiple experiences growing up. This is things like the family of origin. What were the rules and responsibilities within our family? What were the rules and responsibilities within the schooling that we underwent? What are our religious frameworks? All of these things influence who we are as we come into our professional role training. Then we get to our professional role training, and we are progressively socialized into that training through what is initially what we call legitimate peripheral participation. In other words, you get to be in the environment, but you're not really engaged in the environment, to progressive responsibility within the environment. And as that occurs, a number of things happen, including that while you're going through this, you make decisions. And I like to think of this as you put on a different hat. Right. So those of you, if you think back to as you were going through your medical training, you tried on different hats, right? And you said, does this hat, this specialty, this microculture, this microenvironment, this broader environment fit me or not fit me? And then you do that all along the way as you also decide where you're going to work, how you're going to work, what subspecialty you might participate in, et cetera. And then that ultimately results in an integration, they would argue, of professional and personal identities. Okay, so this is the fundamental concept. And then what influences those things? So we already talked about your existing personal identities. One of the elements that happens in medical education is that medical students, as they move into their clinical years, and residents and fellows, and subsequently faculty, have some element of isolation from that prior life. Right? Because of the hours we work and because of the need for us to give up some of our personal constructs as we put the patient before ourselves, right? So that occurs and that results in some shift and dissonance, making this very hard for people as they go through the process. But then there's also impacts from the learning environment. These impacts from the learning environment, where we work, it turns out, are highly predictive of our subsequent behavior. So where we learn and work really matters. And what does that environment look like? There's also our role models and our clinical and non-clinical experiences that influence that, often through conscious reflection and unconscious acquisition of behavior. So in other words, what we see, we do. That's the unconscious. The conscious reflection is, I saw that. Do I agree with that? Am I okay with that? Is that how I want to be or not how I want to be, right? Role models are both positive and negative, always. So there are both people whose your behaviors you say you never want to emulate and people whose behaviors you say you do. And then there are people who are somewhere in between. And then obviously formal teaching, and then things like symbols, the white coat ceremony, for example, your first stethoscope. These are symbols of becoming part of a profession that are important to this becoming. I really love this quote, which is from that paper, that second paper. They are, by that they mean trainees, are impacted by positive and negative experiences with mentors and role models, their clinical experiences, the curriculum, including its formal, informal, and hidden elements, distancing from their previous environment and how they are treated by patients, peers, health professionals, the general public, and their family and friends. They must learn to play the role of physician, acquire the language of medicine, understand the hierarchy of the profession and its power structures, and learn how to live with ambiguity. This is what happens in professional identity formation of physicians. And the idea, they say, is that we begin with helping people understand what is professionalism. That goes back to why is it important that we have a shared framework of understanding, right? So know what it is, know how to show it, that's your competence, show it regularly, performing it, do it, and then ultimately the concept is that you become it. So you become a physician as part of your fundamental identity. This is an interesting concept because many people, I think, are wondering whether that is still true. Do people feel that way or not? And so this is going to be an interesting time as we explore whether this portion, becoming it as an identity, is important to maintaining the values and virtues of the profession and therefore our social contract. I want to make this argument based on my experience alone. I have no proof that this is an ongoing process. In other words, professional identity formation is never done. And I mean that by the fact that my identity personally, and that I've experienced with other people, evolves as my environment evolves. So how I see myself depends on the context in which I am. Secondly, as your role changes in your life, whether when you move from medical student to resident to faculty member to senior faculty member, potentially to leader or teacher or researcher, your identity and the way that you see your professional role and identity shifts. So the way I see myself now and the way I saw myself 20 years ago as a professional is very different. Mostly because I've seen a lot of different worldviews now. Whereas before, I only had my own. So at each experience, you progressively experience more and more visions of what is possible and what people's individual experiences are like, if you're listening. And then lastly, your personal identity changes, right? So when you become a mother or a father, how does that change the way you see your role as physician? Or for me, when you become patient, I was diagnosed with cancer at 35. What does my vision of professionalism and professional identity as a patient look like after that experience? It's different. As your parents go through health crises, it's different, right? So it shapes you and it changes you and it changes your identity. So therefore, as broad context, the big problem with professionalism is that professionalization is developmental and it starts early and it continues at variable rates and over a long period of time. It's also shifting due to our environment, market, managerial forces, globalization, changes in society and what we value. Context matters, cultural factors, personality traits, environmental forces, personal biases, all of these impact what we see as professional. And then very, very commonly, expectations are unfortunately rarely clearly set, communicated, or internalized. And that leaves it open to interpretation and why this issue is always such a complex one. So I am only going to mostly talk about management today, and the things that I bolded are the things that we're going to spend time on. But I think it's really important to say that remediation, to be effective, needs to be part of a broader strategy that includes prevention, thinking about who comes into the profession and what makes for holding the values and virtues that we think are most important to be upheld. Explicit education and curriculum, and then health and education systems and interventions. I would make the argument that much of what the well-being movement is about addressing and impacting these factors, okay? And then in consequences, I will say for that 2%, there will always be a need for a loss of privileges, suspension, dismissal, et cetera. So what do we mean by remediation? So there actually has not been much in the way of a formal definition. You'll see the one that I found online. But what we mean by it and what we put forth in the literature was additional teaching above and beyond the standard curriculum, individualized, critical word, to the learner who without that additional teaching would not achieve the necessary skills for the profession. The reason we think, so as pediatricians, you understand this, this is an IEP. Okay, same concept. Exactly. The reason that is important is because traditionally, and when you look in the literature, most remediation plans have been extension of training in the exact same way, which has failed repetitively as a structure. And so that is not an effective remediation plan. The individualization is critical. But I think, and there's this new emerging literature that's come out starting since 2019 that I think is really important and which has added to my thinking about this, which is that it is also a regulatory process. As part of putting somebody through remediation, you are in effect removing some of their privileges and their individual educational autonomy. And if it fails, you're removing their autonomy from the profession, potentially their ability to practice their profession. That has implications. So going into this, I want to say clearly that there are a number of limitations. There are rare published studies or evidence to guide best practices. There are 2 books, Remediation in Medical Education, published by Adina Collette and Calvin Chow. We're fortunate in this most recent edition, which just came out, to have a chapter on remediation in GME. And then Struggling Medical Learner, this is written by Jeanette Gerasio, who led our remediation program at the University of Colorado for many, many years. And then there is a systematic review and a 12 tips article. At the end of this presentation, you'll see I have listed a bunch of resources, and you guys can have these slides. So the way that we approach all remediation is through this construct. So we gather information through objective input and subjective input, because especially around professionalism, but frequently in other domains, there is an important subjective component. In other words, it's not just what you did, it's how that thing landed on somebody else, right? It's about the impact. So understanding that subjective piece is important. We try to clarify that information as much as possible, trying to identify deficiencies as well as contributing factors. And then we intervene, usually initially through feedback, a learning plan that addresses those things, and then any other addressing of confounding factors, with the idea that we subsequently reassess. We believe strongly in our remediation work that we should not reassess the behavior, that should happen in an alternate environment through actual lived experience of people in that environment. And then this subsequently either results in a successful outcome or we repeat the process. So here's what the literature says about ways that you can approach professionalism remediation. Professionalism and communication are so frequently intertwined that it's hard to really separate them when you think about remediation. Communication is most commonly the way it shows up in the environment. It's the way that people experience it. So for a person who, for example, you believe lacks the professional values and conduct, the most common ways to approach this are by providing them with a mentor or a coach or a role model. Oftentimes in that mentoring, role modeling, and coaching relationships, they'll do readings or discussions of cases, reflection on behaviors, reflection on impact. Sometimes people watch videos and other things as a means of triggering conversation about why the values and virtues matter. And then a really interesting intervention has been putting people into state licensing board actions and watching that. One of the things that I did for a long time when I was on the ABIM board is I was on the appeals panel for people who lost their internal medicine board specialization. That is a fascinating experience, right? To see how people end up in that situation and how they're dealing with it. And so things like that can be truly transformative in people understanding the trajectory they're on and what the potential outcomes can be. For things like involvement and integrity, this is really interesting, but there have been no real significant effective interventions other than rules and sanctions. So when somebody does not do what they're supposed to do, there's a punishment and consequences largely as the most significant outcome for these things. Other things rarely work because most of the time there's an associated lack of insight into how their work. Sometimes you can get them to understand through understanding the impact of their actions on other people. But for the most part, there's a self-involvement perception that's happening where they essentially believe that what they're doing is justified in some way. So you have to figure out how you can move them out of that perception and why it matters that not completing your duty hours logs, which feel incredibly painful to everybody who does them, or your CME. Why is that important? And who is the person who is harmed in that situation? Usually a staff member and possibly your institution, right? So seeing the bigger picture is a part of a significant part of that can be hard. I'm going to talk a lot about the interaction piece, so I'm not going to spend very much time here, but some fun and interesting things are things like tell me more exercises where you have people go and interact with the patient about not about their medical care, not about their the medicine, but about their medical care and their experiences of illness and their family's experiences of illness and what does that look like. And similar kinds of tell me more exercises have been done, for example, in interprofessional environments, as well as relational training around IPE to improve interprofessional understanding. We're going to talk a lot about the other things. There's also something called Charm School that many people get sent to, and I'm going to talk about that a little bit later as well. And then lastly, introspection and improvement. This one is much harder. So this is the people who lack introspection, and I will say that I have formed a bias in this space, which is that if after talking about impact and consequences and helping people understand what's going on, they don't develop any understanding or introspection, you can get those folks only so far. You can get them through the next stage, but those are the likely repeaters, right? They're gonna show back up again and over again. So now I'm going to go through a case, and this is the majority of the talk. So I'm going to talk about Dr. C. I'm going to say clearly that Dr. C is an amalgamation of a number of different people that I have remediated over time. However, many of the people I have remediated over time went through all three of these stages. So the stages are completely accurate. The outcomes are accurate. However, the sub-story is modified to protect the innocent. All right, so we first meet Dr. C in her intern year. Dr. C is a pediatric intern. She has a stellar UME record, excellent USMLE scores. She honored all of her clinical rotations and her sub-Is. She gets some concerns about completing administrative tasks, duty hours, submissions, evaluations, et cetera. There are no concerns regarding her clinical tasks. She's very effective at getting her clinical tasks done, and she's incredibly responsive. As an intern, people consider her to be effective and efficient. Her clinical knowledge and reasoning is truly outstanding. She has a very strong focus on evidence-based medicine and frequently teaches others about new and emerging evidence and what best practices are. That's one of the things she gets known for amongst the students and the team. And patients and families generally find her to be an excellent physician and responsive to their concerns. The APD at this time, who's assigned to her as part of the CCC, provides constructive feedback and behaviors improve. We then come back to Dr. C as a resident. As an R2, some attendings find her to be argumentative regarding care plans, and we'll go into more detail about that later. And some interns describe that in their evaluations, that they feel that she's harsh in her feedback and her expectations are too high. And then what triggers a remediation action is 2 PSN reports. I don't know if you guys call them that here. These are safety reports that are submitted by nurses most commonly, but can be submitted by anybody in an institution. At this time, in this world, it was almost exclusively nurses who submitted them through the PSN reporting system. And 2 nurses submitted PSN reports in very close time frame to each other. The first was when she yelled at one over the phone when she called about a patient order. And the second was when she yelled at another, this time at the bedside in front of the patient, but not the patient's family, who called her stupid after coming to the bedside and finding the patient had deteriorated. So when we get situations like this, we use an ecological framework, and it goes back to that concept I mentioned around professional identity formation and how we form our professional identities. So we try to understand what has shaped this person individually. What are their innate beliefs? What are their individual circumstances and how are they doing as an individual? How are they getting along with other people generally? What's their community and environment like? And what are the potential societal impacts on their behavior? This is a broad construct, but it comes back as being important as you see this remediation unfold. So what do we do to figure this out? We begin by interviewing the referring provider. We look at the description of the event, and we really get into details. Who was involved? Tell me more about what was said. What was the timing of it? What else was going on at that time? What other things might be going on in the environment at that time? Are there any other similar patterns when you look at the evidence? Are there any triggers that you've seen sets this person off? And then are there any broader issues occurring in the division or the unit or the department? Then we review the academic record and we look for similar kinds of patterns. Is there anything in the story that can tell us any information? And then lastly, and I would argue this is probably the most important thing, although without having done that good prior research, the interview is not as effective. So we interview the learner to understand what their perception of the event is. Have they ever done something similar? In what kinds of environments? Do they notice any triggers? What else is going on for them? Are they feeling stressed? Are they feeling burnt out? Is everything going okay in the rest of their life? They don't have to tell us any details, of course. We find that, however, the majority of people actually do, because there is almost always, and at least 50% of the time, when they come to us, by this time, something else going on. And I'll show you more of that literature soon. And then really importantly, at this interview, we're trying to understand whether they accept it and they see the consequences of their actions. So here's what we learned from Dr. C. She was raised in a small rural town. Her father was a very beloved family physician in that community. Her goal is to be an academic pediatrician. She's unsure at this point whether she's going to be a generalist or a subspecialist, but she's thinking generalist, probably hospital medicine. Her primary value is that she really cares a lot about being excellent in her knowledge and clinical reasoning. That's what she sees as being a good doctor, being really smart and knowledgeable. And she believes in direct and unfiltered communication because that's the way her father functioned with his team and with his patients, and because that's what works for her. She feels like she can better understand when someone just talks to her straight. She's very easily frustrated when people around her are unknowledgeable or out of date. She feels that being lazy is unacceptable as a physician or as a healthcare provider, and incompetence should not be tolerated. These are her strongly held beliefs. Her stressors are frequent low priority nursing calls during busy times, particularly during high volume admitting times, and a lack of accountability for nursing completion of tasks. So when things don't get done in a timely manner, when orders have been in for a while, and especially when they've been reminded about. Her emotional state is that she's quite fatigued. She has some early burnout, and she has a 2-year-old child at home. Her husband is a neurosurgery resident and of really limited help and often absent. So what did we do? So we started by offering mental health and social support. We offered her our EAP program, as well as other resources. We talked a lot in this conversation about ways that she could potentially solve for some of her child and home solutions. Not every resident has opportunities to decant some of their other responsibilities, but in this situation, this person did. So we talked about what things she doesn't like doing about her home and domestic duties and how she could outsource those. which is remarkable. A lot of people don't talk about that with people, but I find that this comes up all the time. Like, what do you hate about what you're doing at home? What do you love about what you're doing at home? Keep the things you love and let's talk about how you outsource the things you don't love. And is it possible? And for her, it was laundry, which was very time consuming. And in fact, in Colorado, there's actually quite cheap services that will come and pick up your laundry and deliver it. Very inexpensive compared to other things that we spend our money on, like Starbucks. So it was actually quite doable to offload some of those things. We talked about the systems and societal issues. So I think in remediation, it's really important to acknowledge the very significant challenges we're facing, right? So in this situation, we talked about the reality of the hierarchy of medicine. And while some of the people who are more senior than us may not know some things that we know, they also bring a wealth of experience, and that we need to respect that. And respect of everyone in the environment is important, even if we disagree. So we talked about that extensively. We talked about the fact that sometimes, even when there is best evidence, we as physicians don't always follow it, and that there are a myriad of reasons for that. Sometimes it's acceptable and sometimes it's not, because sometimes it doesn't fit with what's best for the patient for a variety of individual reasons. We talked about the realities of delays in care and why the system is broken and how sometimes those things impact things. And then we talked about gender-based inequities in reporting. And I'll just say that in my 20 years of being involved in this and having remediated now hundreds of people for professionalism violations, women are referred far more likely than men, particularly for communicative struggles. It is even more common in female-dominated domains. So in pediatrics and surgery, we see more referrals of women, and that is compounded by intersectionality. So Black women are particularly targeted in these environments and viewed differently, very clearly tied to biases about what is acceptable and not acceptable in those environments, depending on your gender and your other identities. So I want to be really clear that we know this is true. Like, anybody who's involved in this field has seen it. And so you have to recognize that. And one of the questions that we often talk about in these remediation sessions is, while this is true, I think one of the questions you have to ask is, are you going to work within this system to make it better? Or are you going to only fight against it? And if you're only going to fight against it, you're probably not going to stay in it, right? So you have to sort of decide what you can, this goes back to the professional identity conversation. What can you moderate to get by, and should you? And these are the things that you have to make as a decision for yourself, right? And then we talk about impact. What will happen if this continues? Will you be able to deliver excellent care in the clinical environment if the nurses are all talking about you being a B word? You know, are you able to get along? Are you able to get what you want done for your patients? Are they more likely or less likely to go out of their way to help you if this continues? And then how do you think this might impact your ability to achieve what you want to achieve as an academic pediatrician? Is it more or less likely if this continues? Then we go through a remediation process after we gather all of that information. So we create a simulation-based environment. So we use either high fidelity plus standardized patients, or sometimes just standardized patients alone. These are highly trained standardized patients with excellent improv skills, okay? We create 3 cases. The first case is based on the trigger behaviors we see. It's usually a replication and some kind of what they got in trouble for before, without it exactly replicating it, but some general kind of thing that triggers it. We start easy, we make it harder, and then we end with what's called a mirror case. A mirror case is when they have to give feedback to somebody who is behaving similar to them. The purpose of the mirror case is to determine whether or not they've taken in any of the suggestions and whether or not they can convey those to somebody else. It's sort of like a see one, do one, teach one kind of concept in rapid succession. So the way we do it in the moment is we prepare the learner for what's going to happen. We tell them generally what's going to happen. We talk a lot about the importance of suspension of disbelief and just going in and behaving as they normally would. That is the most important thing. That is the way we can help them. And that is the only purpose of us being here today, is to give them tools in their toolbox. So then they go through an encounter. It's videotaped. We watch the videotape together. Why video? Video is used because most of the time, as those of you, so I don't know if you guys all know this, but about 70% of all interaction is nonverbal. And the way we interpret people occurs in that nonverbal interaction. So by watching how they perform, we can frequently address things that are likely confounding the problems. Body language, tone, et cetera, that we wouldn't get from just listening to it or getting feedback. Then we debrief it. We start with their self-reflection. Then we provide feedback. Sometimes the standardized patient provides feedback based on impact, especially if that's important. And then we set goals and specific behavioral strategies for the next encounter, and then we repeat. At the end of it, we co-create next steps and timelines. We write a written summary and we give it to the participant and the referring supervisors. And then we follow up, usually with informal check-ins with the participant, follow up with supervisors, engagement, sometimes with coaches or other mentors. That is frequently problematic. When somebody doesn't quite make it to a highly insightful end after this session, this can become very valuable. And then sometimes if we're not sure that we exactly hit the challenge, we'll do in situ observations, especially if we think that the environment is probably part of the problem that we need to address. So our study showed, this is a long-term outcome study, and it showed improved self-awareness, resilience, and well-being, more professional interactions, improved work effectiveness, improved feedback and evaluations, and in many cases, changes in career trajectory with people who were problem residents becoming chief residents, going on to stay for fellowship, and even becoming faculty or leaders. And this is some of the commentary. I won't go into this, but I think the one that I really like the best, understanding body language, pausing, listening, and thinking about my own responses and emotions is what we were after. So then what happens? So she actually is one of these people who is successful. She goes on to become on faculty. And she initially does quite well. Patients, families, nurses, and other providers give excellent reviews. Resident and student concerns, however, emerge specifically around terse questioning on rounds, including in front of patients, and then harsh and generally negative feedback with some students and residents describing it as a toxic environment. When this was discussed with her, she became very angry and said, "I'll never be good enough for this place. Maybe I should just quit." She was referred to us again for an interview because by this time we had developed a relationship with her. And what we found out at this time was that she was separated from her spouse. She was now the primary and only caretaker for her child. Her husband was not very involved. And she had begun drinking excessively. She never drank at or before work, but she drank significantly after putting her child to bed and frequently woke up hungover, not sleeping well. It was impacting her ability to consolidate or process what was going on in her day. And as we talked, she revealed a parental history of alcoholism and emotional abuse. So this resulted in an advanced remediation plan. She was placed on medical leave. She was referred to a physician monitoring program. Do you have that here? So in Colorado, it's quite well developed, and they do both ongoing psychological counseling as well as monitoring around substance abuse, and they bring together a variety of different resources, and she was referred to additional mental health support. Why do I bring this up? So this is the literature, and it's shocking, right? So these are people who are referred to an external program for remediation, AKA charm school, like I talked about. And so 23% of them are referred for substance abuse, 23% for a boundary violation, 54% for disruptive behavior. And 70% of these folks reveal an adverse childhood experience, including physical abuse, sexual abuse, emotional neglect, witnessing abuse, and caregiver substance abuse. And this makes so much sense if you think about the trauma response. So for those of you who are aware of the sort of trauma-informed care and what happens when people have experienced trauma, we can see that there are essentially two extreme reactions to that prior trauma, one of which is hyperarousal or the fight outbursts. I am unsafe and I am acting out. I am protecting myself. And then the other, which is withdrawal or dissociation, freezing, disengagement, not involving themselves. And I have seen both of these so many times. And it was only when I started reviewing this more recent literature that I realized that there are probably a number of these that I've missed. So what was the conclusion? This is actually a really good story. And this is of all the 5 people who had seen through this long of a trajectory, They've all had this outcome. So she has maintained sobriety for more than a decade. She's rejoined academic practice. She's successfully obtained and maintained a leadership position, and she has actually won multiple teaching awards. I keep in touch with her. So let's just really quickly talk about whether remediation programs are worth it. So at University of Colorado, this was our infrastructure. It was a half of an FTE of a physician, that was Jeanette Gerasio, and a 0.2 FTE communication expert. This was a PhD. And then we had access to a variety of central resources. At Penn, which was this much smaller program in internal medicine, they divided up their FTE for a GME physician, a UME physician, a professionalism and communication expert. And then they had these uncompensated physicians who were involved, and 9 residents and fellow peer coaches for organization and efficiency only. This is what our data looks like. And I think I just want to, draw your attention to the fact that it was overall quite positive. And this was the early data. So graduation being good standing, transferred and graduating being the primary outcomes. We at this time had nobody who was terminated. In our subsequent data, and these are just the raw numbers, these are numbers, not percents. Raw numbers, oh no, that's wrong. These are percents. From follow-up of our resident data, 89% of them graduated, and only 1 of them was dismissed. 6 withdrew and 4 transferred. The Penn outcomes, very small population, 14, and you can see that the majority of them were organization and efficiency, and so those were all handled by the resident peers. They also don't describe any professionalism remediation. It could be what's in other, but it's not described in their paper. They were mostly focused around medical knowledge and clinical reasoning. They described that it took 45 hours for this remediation. I'll just say that we have a subsequent paper that I'm not presenting here that looked at return on investment. And we found in our data that once the remediation specialist spent 40 or more hours, return on investment was quite low. And that time was largely in clinical reasoning, communication, and professionalism remediation. The rest of them are actually pretty easy. Those 3 are time consuming. My big lesson learned that I'm taking away from this is that having one person be in charge of remediation is a recipe for burnout and consolidates too much information within a single individual. And so really having a team is critically important. As they developed at Penn, they developed that based on feedback from us. And I think for our situation at WashU, what we're looking at is a small core team with highly developed skills, probably 4 or so people, diversity at the specialty level. And then a hub and spoke model with people within specialty in particular, because there is a clear need for specialty specific knowledge, both because of microenvironment, but also because of the nuances that play out. Again, this is only one part of a broader system. What I hope you take away from this is that challenging and unprofessional behaviors happen in all schools and all programs and at all stages of physician development. They are most commonly triggered or worsened by personal or systems factors, and the ability to recognize and impact behaviors on others and a willingness to engage in remediation plan are by far the largest predictors of subsequent success. Effective remediation strategies exist, but they do take time and money. And with that, I will say thank you and take any questions.